excited to have Dr. Raju here with us today. We have a lot to talk about, financial concerns surrounding HHC, and I know that back in April you outlined your vision for the Health and Hospitals Corporation, and the big focus was patient experience. So tell us a little bit about that vision you have and the goals you have for the HHC for aiming for 2020.
Yeah, thank you, Mike. Thank you for having me here today. So thank you for this opportunity. Overall, the ACA was one of the best things happened because it gave insurance to a lot of folks who otherwise couldn't really get into healthcare. But the flip side of it, the ACA also created a somewhat difficult situation for public hospital systems in the country because for the first time, right, in the history, the people who really have insurance have an option to go elsewhere if they're not happy with the services rendered in the public system, right? So what was our captive audience for many, many decades suddenly changing a part of it. So with that, the other side of it is as the people are getting more and more ACA gets insurance, they need to be funded. So a lot of the funding came from the traditional public hospital fundings like UPL and DISH were kind of going down over a period of time. So we take over a public system in that situation, we got to figure out only three things you could do, right? One thing is I can lament about how bad it is, I'm a victim, nobody gives me money, I'm really going down the tubes, and then I keep crying, but nothing's going to happen. That's one strategy, right? And the second strategy is, I can start reducing the services, right? And figure out maybe we should not have all those services, I'm going to do that. But that puts two problems. One, it puts a problem on the vulnerable population. New York City will be in trouble to do that. And it also puts other hospital systems in New York City in deep trouble. Because I always used to say that we are not just safety net for only vulnerable New Yorkers, we are also safety net for other safety nets in New York City. Because we really work on our side of the street, so making sure that these people are taken care of. So that's the second possibility. Third possibility is to look for more revenue opportunities. And at the same time, try to improve the patient experience component. So that is the vision, is get the patient experience, right, up to a level. So we have really kind of put ourselves in a very ambitious goal that we will be in the 93rd percentile in outpatient, patient experience, over 80% in the inpatient patient experience. And then that will keep our patients with us so they won't just leave us. And then we're also able to attract more patients into the system, right? So ACA has actually opened up a lot of doors for us, right? The one is our Metro Plus ability to compete at the exchange level. The basic health plan gives an opportunity to get more patients to the system, right? And our ability to market our plan to some of the New Yorkers is another opportunity. So there is a tremendous amount of opportunity available. So, but they will all come in only if we improve the patient experience component. If the patient experience is not good, you can bring in all these people through various mechanisms and they will leave the system. So that is the overall gist of my presentation. I think we as a health and hospital need to commit ourselves to give the best patient experience to New Yorkers. So that is where we started. And that kind of goes to the basic core of healthcare workers because they all want to do the right thing for the patients. So we said if you do the right things, then we get more market share. If you get more market share, then we have better financial stability. If you have better financial stability, then we continue to carry out a mission of taking care of everybody and turning no one away. So it's it is connected in a nicer way to do that.
Unfortunately, not everyone is as optimistic as you.
I agree.
I know Councilman Corey Johnson at the recent hearing said this wasn't realistic. There's been other people who have commented and said that this is not something that is sustainable. I know even in your speech on April 7th, you said the marketplace is going to determine what hospitals end up closing. And if this is the plan going forward, not everyone is believing as much as you. So how do you convince them?
You are right. I think this is not an easy plan. It's a very ambitious plan. And I think people are right in skeptical, in able to get that done. Now, just flip back 3 years ago, right? Cook County Hospital System said it never be the third largest hospital system, they said they'll never be in black. It'll always be red, right? Every year they were giving, when I walked into Cook County, we were getting $475 million from the county subsidy, right? We brought that down. When I left, it was $145 million, right? We brought it down. And if you look at it today, Cook County is in a positive balance, right? So you're right. It cannot be done. That's one, again, as I said, past performance is not a guarantee for future success. I understand that. But if you don't really aim for it, if you don't do that, there's no other option available, Michael, right? The other option is reduction services, or I can keep crying about lack of money, right? We both of them are not going to get me into very much. Nobody is going to write me a check just because it's going to happen. So, yes, it is an ambitious plan. It has got a lot of issues. It is not. We are going to really get a lot of things correct, but we need to give our employees a goal, a vision, a direction, so that they can move towards that in a way. Will we all get there? I hope we all get there, right? We may not be able to get there in time. That's a possibility, but at least we'll be better off than where we are today. So I am not going to sit around here and keep complaining about how I'm being kind of victimized by the governmental payment system and everything else, because I think we will do that in a different forum, but this is not the forum for that. And we need to we are asking for not necessarily, as I said in Cook County, we are not asking for extra help. We are asking for money to take care of people whom we take care of. That's all we need. If you really start paying for all the uninsured and underinsured people, right? If they want to do that, then we need to really, the amount of money you're going to give is definitely much smaller than the amount of money you will spend. I always say this even in Cook County. If you have anybody else run the system, it will cost you more than what I am costing you today.
And we were speaking before we came up here, and you had mentioned to me too that this is a situation where every hospital in the city is kind of dependent on your success. If you guys have to close hospitals, have to cut services, the patients are going to end up at these other hospitals. Do you want to just talk a little bit about and I would say, I don't want to call it a burden, but just the amount of undocumented immigrants you have to serve, and the I guess a larger number of poor people that you have to serve in the HHC system versus some of your competitors that you're now obviously trying to compete with in this market strategy, and they can appeal to maybe more high-end clients, I guess you could say. Not that we want to make healthcare into a marketplace completely, but this is kind of the reality that we're in right now.
I think we need to understand healthcare. I don't want to get into the divisive healthcare politics of us versus them, because we all needed to take care of it. Just like if Health and Hospital Corporation reduces services, it'll affect the other safety net voluntary hospitals, and vice versa. If they really go under, if something happened, there are hospitals we got closed. Health and Hospital Corporation got the brunt of it, especially in Queens, when we had closure of hospitals a few years ago. So we are all in it together. So I just don't want to get into the politics, of who should remain open, who should close. Health and Hospital takes care of 1.4 million people every year. 475,000 of them are undocumented, uninsured people, right? So there is a big population of that. So we need to really take care of them, right? The way to do that, because I always maintain that healthcare in this country, in my opinion, again, is one man's opinion. It should be a fundamental right. Healthcare should be a human right. Healthcare should be a constitutional right, right? And healthcare should be a civil right, right? I firmly believe in that, right? The richest and the most powerful country cannot afford to, give healthcare to every one of its citizens, residents. That's a problem. So it is not going to be anything different, right, as we do this. But you're right. If we are all in it together, any closure, reduction services, any one of the systems will affect other system, badly. So but the question we need to ask ourselves: how do we want to take care of them? Of course, the disrupt is an opportunity for us to really redo this. How do you want to take care of uninsured or underinsured, folks, and how to get them into care is a part. I think it is more financially beneficial for every one of us if we connect the uninsured, undocumented to care earlier part of the time, as opposed to paying for it at the far end of it. Because you're going to pay for it one way or another. You have two options. Either you can pay for it upfront, definitely cheaper and better, or you can pay for it at the end, where it's going to be more expensive than that. So I think we need to come to realization that it is our responsibility to take care of people who cannot take care of themselves. And healthcare is needed by everybody, right? Just not people who's got a citizenship certificate or some different insurance card. You know, the disease doesn't differentiate. It doesn't say, oh, I'm a diabetic, but I'm got to be, this is uninsured guy, undocumented, so I shouldn't really make him worse. So let me be a little mild with him than the other guy. It's not, that's not the way disease process works. So I think we have a long way to go in our country of trying to make sure that the healthcare is available to all.
And you've been in your position now for more than a year, about a year and a half, almost a year and a half.
That long?
Yeah, close, close. I know that in your April 7th address, you talked a lot about how you feel that you've had success in your first year. I wanted you to recap some of those successes and maybe go past just the basic numbers as far as financially how you've been able to increase revenue a little bit, but talk maybe about the culture. Is the culture among HHC changing, and do you feel like that's changing, or do you feel like there's still more to be done there?
No, there is definitely more to be done. It's a large organization, and there are certain uniqueness of Health and Hospital Corporation, which I am trying to hone in on and leverage that, right? I could probably get up and say, my healthcare system looks like my patients, and my patients look like me, right? Not many healthcare systems in the country can do that. You walk in any one of my hospitals and you see the staff reflects the communities we serve. Go to Coney Island, most of the people who serve them are immigrant Russian population. You go to Lincoln, you have a Latino population, the employees do the Elmhurst, you have the South Asian population, most of the people who serve there are, our employees are South Asian. So that is a uniqueness. So the patients feel very comfortable in our hospitals because you can always find somebody who looks like you, talks like you, and who speaks your language. So that is a big advantage and leverage. And that's what we are trying to get our employees to understand, that we are uniqueness of our system, and how do you leverage this uniqueness to provide best care for the people. So my hospital is not intimidating. You can't walk in there and you get intimidated because I don't have all those fancy stuff in there. It's all very straightforward stuff in there. I don't have, piano playing somewhere. I don't have those things. But it looks like a hospital. It looks like a welcoming place. It looks like the person who meet, the first person is probably somebody who looks like you. So that is a uniqueness. So I want to really leverage on that. That is where I'm driving this organization to. That's where I believe that we need to move as a system. But we're not there yet. It's a long way to go because we need to figure out how do you get people into this. So my message was very simple, right? For the physician workforce and the provider workforce, let's not treat by disease process, because we have really gone ourselves into this. It always used to cringe when I used to be, doing, rounds, everything else. People say, how is a gallbladder patient in 4th floor, right? How is a trauma patient 3rd floor? Is a heart failure patient going home? It's not a heart failure patient. This is Miss Jones, who happens to have heart failure. I think we need to really start moving away from the disease process in individuals. Then we'll develop patient experience we're talking about. So that is a fundamental cultural shift. We should stop mentioning the patient by the disease category. We should start recognizing them as an individual, right, who happens to have a problem, right? So I think if we can get that done in health and hospital, the experience will get better. We'll be financially better off, and hopefully we'll be able to carry on our mission.
So 2020 is not that far away in the grand scheme of things. And we do these healthcare forums every single year. We'll probably try to have you back next year as well. When you come back next year, what would you need to see to be able to gauge and see if this is working? Of this focus on patients and just this change in culture is working, and what would be like a market goal? You could say like, yes, this is it. Maybe go back to the city council and say, yes, this is working.
I think there are a couple of things. One is, the first part of it is our HCAP scores should go up. Our patient satisfaction scores will show an improvement in the 1 year. We will find our Metro Plus membership will improve, right? We are close to 500,000 now. We will be 625 next year, and we have planned to get that done. The market share is we are 1 out of 6 New Yorkers. We want to be 1 out of 4 New Yorkers. Hopefully, we'll be by 4.5, 6 and 5.5 next year. Then we'll move towards that, right? And those are some of the major areas where we are going to move along. So in a year, we will make that first step, second step. But again, this is not going to be a walk in the park. It's not going to be easy. A lot of people felt the same thing, like you say, Michael. So why would you go and put yourself at risk saying all those things? You are much better off as a leader complaining about the lack of reimbursement and move on because that's not your fault, right? You can always get them people around it. But I think a responsible healthcare leadership is putting yourself up there, declaring bold goals, and hold yourself accountable. If you get it done, that's fine. If you don't get it done, I lose my job. That's okay. At the end of the day, I always say, public hospital chief, if I really want the job badly, I can never do the job. So I should be ready to put this all on the line, able to get it done. So I am sure we'll get it done because we have a great workforce, and I trust them. I believe that they're really very dedicated. So failure is not an option. So we'll come back to you in 2020 and we'll tell you that we got it.
We hope that you get it in by 2020. Before we open up to the audience really quickly, I just wanted to get a sense. I know that the city council encouraged you to find other revenue streams. We don't need to talk about the specific examples that they pushed forward, but is there any activity going there? Is there any I guess other ideas that you guys are floating around as far as increasing revenue that maybe is more tangible than just improving overall quality?
I think we are planning to, get Metro Plus into Staten Island, right? Because there's a large population there, especially on the northern portion of Staten Island. And with the full disclosure, I am from Staten Island, so that's where I lived for 36 years. So there is healthcare disparities, with the existing northern part of Staten Island. We need to work on that. So to do that, we got to get ourselves into, Staten Island. Metro Plus will enter that. And then the other revenue options continues to be, we'll continue to advocate for the charity care dollars, right? How the charity care dollar methodology is. At the present time, the way it is set up, that we will be the last on the line. So when the dish cuts comes in, we'll be the first one to lose. So we will be working very closely with our state colleagues to make that, do that, because that's one other option. And overall increase in market share of our folks, where we want to do that. We'll be working closely to increase the primary care access for the mayor. Mayor has announced about 16 underserved areas in New York City which need more primary care. We will be working closely with the mayor's office to expand those things to do that. Thanks to my predecessor, we got the federally qualified lookalike status for some of our system, some of our DNTCs, and we'll continue to expand that. So there are multiple ideas how to do this, right? So hopefully all these things will get us where we want to be by 2020.
Great. I think we have time for one question. If anyone wants to ask us, we have someone over there, Jasmine. If you want to bring them the mic, whoever you choose. Sorry.
I love you.
Tell us who you are first. Yeah.
Hi, Thomas Lopez Pierre from Upper Manhattan. My question is, concerning the disparity among education, housing, could you speak a little bit about the disparity among healthcare for the minority community, particularly African American and Hispanic community? And could you talk about, since Blunt Talk, which I have to admit, it was very refreshing, you came in day one, where do you see dealing with reducing those negative statistics? Thank you.
Healthcare disparity is a bigger issue, right? And one of the reasons I went to Chicago, because Donna Brazil wrote this primer, which we said, place matters. The place matters is really opens your eyes. If you are African American living in the south side of Chicago, you died 12 years earlier, right? It's only small river, Chicago River. You can actually kind of jump over it if you wanted to, right? If you live in the north side of Chicago River, you got excellent healthcare. If you live on the south side of Chicago, you get poor healthcare, right? It has got a big problem. I always thought, in my original idea that is all about access, right? Let's give more access, geographically convenient access. That's what we did in Chicago. That we got 138 different primary care spots all across Cook County. It's 200 miles, Cook County, up and down. So we said we're going to have a primary access point every mile and a half, right? So that people can get into that. Then I got a little smarter, and as I look into this, it's just not access anymore. It is the other socioeconomic conditions which can happen. So now I am of opinion that healthcare leaders is not about just purely healthcare. We need to be social change agents. You can never improve the healthcare of a community unless the public safety, transportation, poverty, education, economic, jobs, all those things need to come with that. So the initial idea that somehow, we can improve the health of a community because I go there and put a clinic over there and everybody comes in and be able to do that, that is not a very viable option. So I think we need to rethink the role of public health, the role of healthcare leaders, what they're supposed to do with it. I should be worried as much as healthcare as much as about the housing. I should be worried about, the public safety of that. It was extremely open to me. In fact, that my eyes got open about maybe 8 years ago, but I never catch on. We had this, we were having problem with our readmission for congestive heart failure patients. So we said, why are we not doing this? So I said, okay, let me just follow patients, see what happens. So I went to this nice old lady. She lived in a walk-up apartment in South Bronx, about 3 floors into that, and the elevators were not working, right? Normally, they don't. So we walked into there, I sat down, and we started talking. We said, I want to tell you something. You told me on the discharge instruction, walk half a mile every day. I am not walking. This is the prison for me because I can never get down 3 stairs, and I cannot walk outside because there's no public safety issues I got. So we believe that somehow we wrote a piece of paper saying that please walk half a mile, somehow everything gets done. It doesn't get done that way, right? That is what we call the arrogance of medicine. We believe that just because I give a piece of paper, somebody follows it up. And if they don't follow up, it's their fault. It's not my fault. We have a great name for it. We call them non-compliant patient. So in other words, medicine is never wrong. It's always the patients are wrong, right? If the treatment does not work, it is not my fault. It's actually patient's fault, right? So we have to really move away from that. You can never, ever improve we never achieve the population health unless we look at all those things. And we have done a good job of it. In fact, some of the areas in Deputy Mayor is here. Last time when we were administration, we have Kamba housing project inside Kings County. We built those housing. Right now we have a new housing project next to Metropolitan, 99th Street, and the Draper Hall, we are going to build more housing. You got to do all those things as an organization. So we cannot just be a healthcare organization. We got to be a social change agency as a part of it. And we need to work with everybody to get it done. Otherwise, we will continue to have the disparities in this area.
Dr. Raju, everyone give him a round of applause. Thank you very much.